Chapter 9 on articulations. So our learning objectives, as always. So articulations are the fancy word for a joint. So this is any place where two or more bones meet. And there's usually cartilage involved in that. And so we say they articulate with each other and they form a connection. You and I have what's called an articulated skeleton, meaning it's made of a whole bunch of individual bones, 206 individual bones that meet, that touch each other in a lot of places. And where they touch each other, that's the articulation. This is what allows you to move around. If you were one big solid piece of bone, there would be no way that you could move your arms and legs and do all the things that you do. But because our bones are arranged the way that they are and the muscles are overlapping and spanning these articulations, these joints, when the muscle contracts, it allows the two bones to move. So articulations are our topic. Some joints allow for movement between the bones. At these joints, the articulating surfaces of the adjacent bones can move smoothly against each other, or at least we hope they move smoothly. And then other joints that you have in the body are designed more for stability and they provide little or no movement. So we're going to see that there's a pretty wide range in the movement that occurs. When we think of joints, we typically think of elbows and knees and shoulders and those kinds of things. But any place a bone touches a bone is considered to be an articulation. The stability and movement of a joint are inversely related to each other. The more a joint is moving, or it can move, the less stable it is. The shoulder is a classic example here. Our shoulder has the ability to move 360 degrees. You can turn your arm all the way around, right, in a big circle. But it's a very unstable joint. Think about something like your knee, which has a pretty limited range of motion, just open and close, right? And it is a much more stable. So the more movement you have in a joint, the less stable it is. We look at two different classification systems, and I'm going to explain both of them. The functional classification of joints is determined by the amount of mobility. How much does it move between those two bones or those adjacent bones? So we can classify joints as being a synarthritic or an immobile joint. It doesn't have any movement at all. An amphiarthritic joint, meaning that it has a little bit of movement, or a diarthritic joint, meaning that it's freely moving. All right. Synarthrosis is a condition of a connected joint. Syn means connected. Amphiarthrosis means both. Amphi means both, like an amphibian, right? And so it has a little bit of movement. And diarthritic, di means two. The structural classification, on the other hand, is how we describe the articulating surfaces and how they're joined to each other. So what's putting them together, in other words. And so we're going to look at how we can have fibrous connective tissue, cartilage, and a fluid-filled cavity with these. So let's look at our fibrous joints first. So the adjacent bones are going to be connected directly to one another by some type of fibrous connective tissue. There is no joint cavity between them. There's no space in between them. These joints are immovable. They do not move. There's three different types of fibrous joints that we look at. We look at sutures, which means they are sewn together, like what we're going to see in the skull. Syndesmoses, this means that, or they have a band of tissue that's holding them together. And gomphoses, which is Greek for the term bolt, which is what we see with the way a tooth is in the socket of your jaw. And so there's some pictures for you to look at. A suture, again, you saw these in the skull. and that's where you have two bones that are literally right next to each other, and they're sewn together with this piece of connective tissue, so they're pretty sturdy. A syndesmosis in the middle is where you've got a sheet of tissue or a band of tissue. You see this with the radius and the ulna, which is what we have there in that little blue area that's in the box. That's the fibrous connective tissue that's holding those two bones together. And then finally, a gomphosis is what we see with the tooth. So a tooth is technically a bone, um, and it is in the alveolar socket of your jaw, in your mandible and your maxilla, and so it's where a bone meets a bone. None of these we want to move, right? We do not want our teeth moving around in our jaw, and we certainly don't want our skull moving around at all. The skull plates. Think about if you didn't have these sutures in your face and the actual cranial vault. Every time you did something like chew, your whole face would be moving. So cartilaginous joints, these have adjacent bones that are united by some type of cartilage. They lack a joint cavity as well. The bones are joined together either by a piece of hyaline cartilage or a piece of fibrocartilage. They're not highly movable. They do move a little bit, but not like we see with the freely moving joints. Two different types: synchondrosis, which is connected by hyaline cartilage, and a symphysis, which means that they are growing together, which is connected by fibrocartilage. So that's how those two are different, just by the cartilage, the type of cartilage. So a synchondrosis, again, the bones are joined by a piece of hyaline cartilage. You saw this with the epiphyseal plate. The epiphyseal plate, if you remember, was the plate, the growth plate in a long bone, and it was made of cartilage, and that type of cartilage happened to be hyaline. And so that's what they're showing you there with the blue. You can kind of see the little blue there. All right. Most of these are pretty immovable, and we would want them to be immovable. A symphysis is where you see two bones that are joined by fibrocartilage, and a classic example of this is the pubic symphysis, which is that band of blue tissue that you see between the two anterior hip bones in the very, very front. So it's going to allow you to move your legs because your pelvis can kind of move a little bit. It's slightly movable. If you didn't have that there and that was a solid piece of bone, you'd have to hop like a bunny. Synovial joints. So these are bones that are separated by a fluid-filled cavity. And these are the things we think of when we think of joints. This is what we think of. We think of knees and shoulders and all that sort of stuff. All of these are diarthritic, meaning that they are freely moving. They allow several types of movement. Mostly where we see these are your limbs, so your arms and legs. They're going to have bursa and tendon sheaths that we'll be talking about, and they are classified into 6 different types. Synovial joints are the most common type of joint in the body. It has a key structural characteristic for that synovial joint is the presence of this joint cavity. We haven't seen that with any other type of joint that we talked about. The joint cavity is a fluid-filled space where the articulating surfaces of the bones are going to be in contact with each other. The bone surfaces of a synovial joint are not directly connected to each other. They have some type of a fibrous connective tissue or cartilage between them. So looking at the right, you're seeing a generic form of a synovial joint. No synovial joint really looks like this, but it's trying to get the idea of that joint capsule that you have, and that the bones aren't butted right up next to each other like we've seen with the other types of joints. So some information about that joint cavity. The walls of the joint cavity are formed by the articular capsule. The capsule is a fibrous connective tissue that is attached to each of the bones just outside of the area where the bone is going to articulate. Friction between the bones is prevented by a thin layer of hyaline cartilage on the cap of each bone, and that's what they're showing you with the light blue, that light blue that's capping each of those bones. That's the remnant of your fetal skeleton. So that whole process that we talked about last chapter with chondral ossification as the bone was converting over from cartilage into bone. What is left is that blue cap on each bone, and um, that is the articulating surface or the hyaline cartilage. The inner surface of the articular capsule is the thin synovial membrane. The cells of this membrane are secreting a fluid called synovial fluid that provides lubrication and reduces any additional friction that may be happening. This fluid also provides nourishment to the articular cartilage because remember, cartilage is avascularized, so it has to be able to diffuse and get its nourishment and take away its waste that particular way, and that's what the synovial fluid is going to be doing. The synovial fluid is a derivative of your blood plasma. It's secreted into the joint by the cells in the synovial membrane. So that fluid comes from the plasma of your blood. Outside of the articular surface, the bones are connected by ligaments, which are strong bands of fibrous connective tissue. Ligaments are classified based on their relationship to the fibrous articular capsule. Extrinsic ligaments are located outside of the articular capsule, and intracapsular ligaments are located inside there. So we're going to look at the different names of those. Some additional structures that are associated with our synovial joints. These aren't technically part of the synovial joint, but they're closely associated with them. So few synovial joints of the body have fibrocartilage structure located between those articulating bones. We call that the articular disc. If it is a larger one, like we see in the knee, we call it the meniscus. So you probably have heard about people with their meniscus, and the meniscus is made of fibrocartilage, and it is found between the femur and the tibia, sitting in between there. It is like the letter C. It's like a normal letter C and then a backwards letter C that are facing each other. Some other things that we find in the synovial joints that are associated with synovial joints are the bursa. So you may have heard of bursitis. A bursa is a thin connective tissue sac that's filled with lubricating liquid. I think about them like ball bearings. And so they're going to be located where you have friction, where you have skin and ligaments or muscles or tendons, and they're moving around, and so they're rubbing across one another. And so these little sacs of synovial fluid are in between there, and what they do is allow that to slide easier. So they prevent friction between the bones of the joint and any overlying muscle and tendon and skin. So sadly, all of these bursa have different names. We don't have to know them, but if you decide to go into orthopedics, you certainly would need to know all of them. But just to give you an example, on the very front, this is a knee that we're looking at. On the very front, you can see the patella on the right-hand side of the picture, and then look right on top of that, there is a prepatellar bursa, and then you go down just a little bit more, and there's an infrapatellar bursa, and they're usually named according to their location. There's a subscapular or a suprapatellar bursa as well, and you can see them. They're kind of outlined in dark blue. So they're pretty consistent. They're not just randomly anywhere in the joint. They have their places where they would typically be found. A tendon sheath is similar to a bursa, but it's smaller. It is a connective tissue sac that surrounds a muscle tendon at places where the tendon crosses the joint. It also contains that lubricating fluid, and it allows for smooth motion of the tendon during muscle contraction and joint movement. So ligaments and tendons, I've kind of thrown these words around already, so let's get a clear definition on these. A ligament is a narrow band of fibrous connective tissue that connects two bones. So ligaments hold bones together. Tendons, on the other hand, is a dense connective tissue that is attaching a bone to a muscle, or to some other type of structure. So when we think about tendons, it's a bone to a muscle, and ligaments is a bone to a bone. So our synovial joints have different types, and we can subdivide those based on the shape of the articulating surfaces of the bones that make that joint. There are 6 different types that are going to allow the body to move in a variety of ways. We're going to look at pivot, hinge, saddle, plane, condylar, and ball and socket. You're probably thinking right now, my gosh, there's a lot of words involved in this. This chapter really lends itself well to making flashcards. So you might want to make yourself some flashcards because there's just a lot of terminology associated with this chapter. So let's look at these different joints, types of synovial joints. So pivot joints allow for rotation around the axis, such as between your first and second cervical vertebrae. The second cervical vertebrae has a piece of bone that sticks straight up called the dens. And so it's just like this little post of bone that is sticking up. And the first cervical vertebrae is actually sitting on top of that, and it twists back and forth. So when you shake your head no, go side to side, that your first vertebrae is pivoting around that second vertebrae on this structure called the dens. So that's what they're showing you in the picture over on the right. A hinge joint is just like the hinges on your cabinets or your door. It allows things to open and close, open and close. So you're just going to have movement in one direction. So think about things like knees and elbows. Those are hinge joints. A saddle joint is going to be the articulation between the trapezium, which is the one of your carpals, your wrist bone, and the first metacarpal of your thumb. So the only place you're going to find this saddle joint in the body is your two thumbs. And it's what is allowing you to have an opposable thumb. And we'll talk about that some more in just a few minutes. Plane joints, that's when you have two bones that are literally gliding by each other. So the carpals, you have 8 bones that make up your carpals, your wrists, and 7 bones that make up your tarsals or your ankles. And those are kind of squarish bones, and they have some movement to them, and they glide next to each other. They slide and move next to each other. Condylar or a condyloid joint is going to be found like at the radial carpal joint in the wrist. That's the classic example of that. So where the radius meets the radius, which is the bone on the thumb side, where it meets your carpals, you're going to have a condylar. It's kind of an oval shaped joint. And then finally, the big joint that we always think about are the ball and socket joints. So the hip and the shoulder are ball and socket joints where the head of one bone is going to fit into a cup in another bone. It's really obvious at the hip because you have what's called the acetabulum that the head of the femur is sitting in, but you have it at the shoulder too. The shoulder, you have the head of the humerus that's sitting in this depression on the scapula that's called the glenoid fossa. So make sure you know those different types of synovial joints. What about some of the movements? So when I used to teach this class in person, I had everybody stand up when we were doing these, and they would actually do all of these movements. So we'd get a little bit of exercise in class. So you can just follow along here if you like, but doing the movements helps to understand what these different joints are doing. So remember, all muscles attached to bone or connective tissue at least 2 places. And so when we look at the way a bone is oriented, let's just look at your arm for a second. All right. You've got your humerus up at the top, and then you've got your radius and your ulna down at the bottom. The muscle that is going to connect those two, that's going to allow for movement, is going to span that joint we call the elbow. All right. So we have to have muscles are going to have to attach to one bone, span the joint, and then attach to the bones below because that muscle is going to contract. And when it contracts, it's going to cause that joint to move. Okay. If the muscle was attached to the top of the bone and the bottom of the same bone, when it contracts, you get a nice lump, but it's not going to move anything, right? We want to cause movement. That's the whole point of the way the muscles are oriented. So let's talk about how that muscle is attached to the bone. The place that it's attached, the bone that it's attached to that's not moving. In the case of our arm, let's talk about the bicep brachii for just a second. So it attaches up at the humerus. It's going to span the elbow joint, and then it's going to attach at the radius on the lower part of your arm. And right, when you contract that muscle, your arm contracts, right? You make a muscle. So the muscle place it's attached at the top of the humerus is called the origin. Where it is attached down at the radius would be the insertion. So again, the muscle contraction is going to cause the insertion to move towards the origin. Movements are going to occur in our transverse frontal and sagittal planes. Synovial joints allow the body a tremendous range of movement because if we didn't have all of this stuff happen, again, you would just be one big block of bone. Each movement at a synovial joint results from the contraction and relaxation of the muscles that are attached to the bone on either side of the articulation. So the whole idea is that muscles are going to span our joints so that we can have movement occur. There's 3 general types that are based on the plane of movement: flexion and extension, which is along the sagittal plane. So remember the sagittal plane? Remember which direction that is? It's making a right and a left. Okay. Abduction and adduction are going to be along the coronal plane, and circumduction and rotation are not associated with any plane. They can cause movement in the coronal and the sagittal planes at both the same time. So let's talk about these. Flexion and extension. These are movement that take place within the sagittal plane and involve anterior or posterior movement of the body or limbs. Flexion is when we decrease the angle between the 2 bones. So think about when you flex your arm, you decrease the angle between the humerus and the radius and ulna. When you extend, you increase the angle between those 2 bones. Hyperextension is moving beyond the normal range of motion. So let's take a look at some pictures here. That always helps. So we're looking at bending over. When you bend over, you are decreasing the angle between the upper part of your body and the lower part of your body, and that's a flexion. When you stand back up, you're increasing the angle between the upper part of your body and the lower part of your body, and that's extension. And if you can bend way back, that's called a hyperextension. Okay, same thing would be true. Look at the far right-hand side. Let's look at the angular movement of the head, right? And so we have flexion and extension of the neck. When you take your chin and you put it down on your chest, you are decreasing the angle between those 2 bones. And so that would be considered flexion. When you straighten it back up, that would be called extension. And if you put your head back, that would be hyperextension, beyond the normal range of the joint. Okay? Let's look at it with the arms and the legs. So flexion with your leg would be taking your leg and bending it at the knee. So you would have decreased the angle between the lower leg bone and your backside, right? And so that would be flexion. And then when you straighten it back out, it would be extension. With the arm, same kind of thing. You flex and you extend. You increase the angle, you decrease the angle, then you increase the angle. Okay, everybody good with flexion and extension? Abduction and adduction. These are 2 words you got to look at real close. So ABD and ADD. Okay, ABD and ADD. These occur within the coronal plane and involve medial and lateral movement of the limbs, fingers, toes, thumb, that sort of thing. Abduction moves away from the midline. You're abducting, you're moving away. Adduction adds towards the midline. Okay. I always think about the classic piece of equipment at the gym called the adduction abduction machine, where you sit in it and you basically move your legs back and forth, and you adduct and abduct, adduct and abduct, adduct and abduct, open and close your legs, right? That's the idea of abduction, adduction. But you can do that with your arms too. If you take your arm and you lift it up at the side, then you've abducted your arm. Then you take your arm and you lower it back down to your side, then you would have adducted your arm. Okay? Circumduction is the movement of a body region in a circular manner in which one end of the body region stays relatively stationary and the other one makes a circle. So you can do this like with your wrist. So if you try to make your wrist go round and around, or you can do it with your whole at your elbow. So your elbow stays pretty much in the same place and you're making a circle with your hands. You can do it individually with your fingers. Can't really do it with your toes, but you can do it kind of with your ankles. So that's circumduction. Rotation is when the you're rotating around that pivot joint like I was talking about when we were talking about pivot joints earlier, or at a ball and socket joint. So rotation is when you're rolling things out or rolling it in. So let's talk about thighs. Thighs are an easy way to talk about that. If you take your thigh and you turn it out, so you point your toes out to the side, that would be a lateral rotation, and then you can roll it back in. It would be a medial rotation. Supination and pronation, this is movement of the forearm that results from rotating that radius and the ulna. So in anatomical position, remember what that was? Was when you were standing upright and your hands were to your side, your palms were facing forward. All right. In that position, the radius and the ulna are parallel to each other. When you flip your palm over into the pronated position, the radius and the ulna form an X. They cross over. So supinate is when you hold your palm up, and pronate is when you go down. So here's the silly way I remembered this. You could only hold soup in your palm if you had your palm up or in your hand, right? You couldn't hold soup in your hand if you had your palm down. So that was kind of how I remembered that supination meant palms up. I know I have really silly ways of remembering this stuff, but it worked for me 40 years ago and it still works for me today. Dorsiflexion and plantar flexion, these are describing movements at the ankle joint. So dorsiflexion is when you bring your toes up. So dorsal is the top of your foot. Flexion means you're decreasing the angle between the top of your foot and your lower leg bone, your tibia. It's like if you're going to walk on your heels. Okay. Plantar flexion is pointing your toes. So the bottom of your foot is called the plantar region. And when you point your toe, you literally decrease the angle from the bottom of your foot to the back of your leg. So both of these are flexion movements. We normally have one flexion and one extension, but in the case of the ankle, it's dorsiflexion is going to be toes up, plantar flexion is going to be walking on your toes. Inversion, eversion is also describing what's going on at your foot. And this is the classic, what you see classically when somebody has injured their ankle. In the notes, you'll see either inversion or eversion of the ankle. So inversion is when you roll the foot, the bottom of the foot inward, and eversion is when you do it out. Okay. These are really important motions that you do all the time. You don't even think about it because it's what helps you keep your balance when you're walking, and especially when you're moving directions, changing directions quickly if you're running or if you're playing basketball or anything like that. But it's really important for balance. And when people can't do that slight eversion, inversion, then they start to lose their balance. If somebody inverts their foot incorrectly or everts it incorrectly, it can result in an injury. I'll give you an example. My sister-in-law, a couple of years ago, was walking the dog on ice, which they live in Texas, and it doesn't ice in Texas very often. And the dog kind of bolted a little bit, and she slid and she everted her ankle when she did that, and she broke her ankle uh, in that whole process. She actually broke the tibia, the down at the bottom of her ankle bone, or at the bottom of her leg. Protraction and retraction. This is an anterior posterior movement of either the scapula or the mandible. So we can talk about it with your jaw, or we can talk about it with your shoulders. For the mandible, protraction occurs when the lower jaw is pushed forward to stick out, and then retraction when you come back. With shoulders, it's when you roll your shoulders forward and roll them back. Depression and elevation, again, also can be used to describe the mandible or the scapula. Elevation of the mandible is an upward movement where you close your mouth and bite on down on something. Depression is when you open it back up. Shoulders, obviously, when you pull your shoulders up towards your ears and then drop them back down. Opposition and reposition. Told you we would talk about that opposable thumb. Again, here we are. The thumb movement that brings the tip of the thumb to the tip of your finger. All right. That is going to be opposition. Reposition is when you put them back in their normal place. So this is what makes you and I unique as primates, is this opposable thumb, because this allows us to use tools. So I want you to think about how many things you do every day that involve your thumbs and your first finger or your other fingers. Using a fork, right? Driving your car, brushing your teeth. I used to always challenge my students to try to do things without their thumb. It really is challenging. So we don't do it anymore because we have a different kind of phone. But back in the day, we had phones that you actually text messaged with your thumbs. You had a little tiny keyboard and you text messaged with your thumbs. And if you didn't have opposable thumbs, you wouldn't be able to do that, right? So opposable thumbs are something that's extremely unique. Losing your thumb is a really, really big deal, right? If you lose your thumb, it's going to make it so that you have a major disability to do a lot of things and a lot of jobs you wouldn't be able to do. Um, when you lose your thumb, they actually can take your big toe and surgically attach it to your where your thumb was. You can look that up. You can look up a big toe as a thumb. So this is why I always say keep getting pedicures. Keep getting your pedicures. Even guys, get your pedicures, because if they ever have to take your toe and put it up at your hand, you want it to look halfway normal. So get a pedicure. Now we're going to talk about the different joints. So you're going to see this in lab as well, but I just kind of want to review this with you and give you some ideas of what is all involved in each of these joints. Some of them are really complicated, more complicated than you would have ever imagined. So the glenohumeral joint is the big fancy name for a shoulder joint. And so this is the articulation between the head, that rounded portion of the humerus, and that caved in, concave structure on the lateral side of the scapula that's called the glenoid cavity or the glenoid fossa. This is the one that I mentioned in the beginning that has the greatest range of motion, because it has it's the way that it's all put together. It also is the one that's most easily dislocated. So they always say the one that's most easily dislocated versus the one that's most commonly dislocated. And they talk about the difference between the jaw and, because jaws dislocate pretty easily as well, and shoulders. In my experience, it's been more commonly with shoulders. Shoulders dislocate a lot easier than anything else. Some of the ligaments that are associated with the shoulder joint, there are a bunch, but there are several that I want you to at least be aware of. The coracohumeral ligament goes between the coracoid process of the scapula to the anterior humerus. So it's going to span across those two bones. There's three ligaments that are going to be called the glenohumeral that are literally going to go from the glenoid cavity to the humerus, and they help to strengthen the superior and anterior capsule walls. So I pulled this picture up for you, and it's got tons of stuff labeled on here, and you can see how very complicated shoulders really are. And so you see all of those blue things are different ligaments and tendons that are holding that shoulder in place. The knee joint, this is the largest joint in the body. The knee functions as a hinge joint, allowing flexion and extension of the leg. The knee joint has multiple ligaments that provide support, particularly in the extended position. It is also the most commonly replaced joint, and I can tell you that that's not fun because I had mine done 3 years ago, and it is incredibly painful. So be kind to your knees, because mine wore out because I used to do a lot of aerobics and running and all that sort of stuff, and eventually they just gave out. And so I've had my knees replaced, and it is extremely painful. So knees, taking a look at them, lots of different structures holding knees together, right? Lots of muscles, lots of ligaments, lots of tendons. There are lots of bursa. There are lots of other things that are holding these together. A really complicated joint. Outside of that articular cartilage, you have two extrinsic ligaments that you have probably heard of before. There's one called the fibular collateral ligament, or the lateral collateral ligament is the other name for that one, and that's just fun to say. And then the tibial collateral ligament, which is the medial collateral ligament. So the tibia is on the medial side of each leg, and so the ligament that attaches the tibia to the femur is the tibiolateral, and then the fibula is on the lateral side of each leg and the lower leg, and the ligament that goes from the fibula up to the femur is called the lateral collateral. These help to support and stabilize the extended knee and prevent side to side or rotational motions between the femur and the tibia. So when you turn your leg, both the femur and the tibia go. One doesn't go one direction and the other doesn't go the other direction, which would be horribly uncomfortable. Inside of the knee, there's two intracapsular ligaments, the anterior and the posterior cruciate, the ACL and the PCL, and a lot of people have heard of these. The PCL prevents the femur from sliding forward off the top of the tibia. The ACL resists hyperextension and prevents the tibia from sliding forward. So if you look at this, we're looking down into your tibia. And so you see the anterior cruciate up at the top, you see the posterior cruciate at the bottom. Cruciate means to cross. And so these ligaments literally cross between the two condyles of the femur. So there's two big knuckles on the femur, and they cross between there. And so that's why it looks like the letter X. So that's why they're called cruciate. So they go from the front and cross through to the back, and one goes from the back and crosses through to the front. Okay. These two ligaments, unfortunately, if you have a twisting event, they can tear, and they are never going to heal themselves. Ligaments are incredibly difficult to heal. Sometimes if you have a tear in the lateral or the medial collaterals, sometimes they'll heal themselves without surgery, but these guys will never heal. And so when these get torn, you have to have knee surgery. So you've seen people, I'm sure, walking around with the leg brace that goes all the way from their hip down to their ankle because they had cruciate surgery ligament, because you literally cannot have any twisting that happens whatsoever while that healing is happening. You see them on crutches when that happens. One of the other things you can see in this picture is you can see those two meniscus that I was talking about, the one meniscus that's actually got two sides. So look for the letter C. It's blue. That's going to be the medial meniscus. And notice that the lateral meniscus looks like the backwards letter C. And so they're like two cup-shaped structures that are butted up to each other, and the condyles of the femur are sitting in those. They're just made of fibrocartilage, and you can tear those. And so if you end up with little jagged tears in there, when you go to try to move your knee around to hyperextend or to extend or flex your knee, it gets caught on those little tears, and it's very painful. So there are a combination of injuries that can occur to a knee. The one we talk about, because it causes so many problems, is when you get hit on the lateral side of an extended knee. So like soccer or rugby or football or basketball, that's where these kinds of accidents happen. So you get a blow to the outside, the lateral side of the knee, and it creates what's called the terrible triad injury, in which you have damage on the inside of the knee. So the energy goes right through the knee and causes all kinds of problems on the medial side. So the tibial or medial collateral ligament gets torn, the medial meniscus and the anterior cruciate ligament are all damaged, and you have a lateral blow. The same thing's true when you get a medial blow, but they're far less common. Lateral blows happen because somebody's kicking a soccer ball and they accidentally kick you, right? Or you take a hockey puck to the outside of your leg, or any of those kinds of things. So you'll see more of those kinds of injuries than you will with somebody who's been hit from the inside of the knee. So when they hit on the medial side, it causes the same kind of damage on the outside of the knee. Treatment for this is going to involve surgery and physical therapy, and it can take months for all of that to be healed. So there's that idea. This looks like you're looking at a knee from you are looking at a knee. You're looking at it from the lateral side and the medial side. There, it almost looks like you're looking at it from a side view. You're actually looking at it from a little bit different view here. So you have this direction of force coming in from the lateral side. So you're looking straight on that knee. You're not looking at it from the side, and you can see how it has bent in that lateral collateral, but it didn't tear it. But that energy traveled all the way through and tore the medial collateral ligament. It tore that anterior cruciate ligament, and it tore that medial meniscus on the opposite side. A little bit about your elbow joint. So elbow joints are a unilateral hinge joint that's formed by the humeral ulnar joint. The elbow joint is a complex joint that's actually made of 3 different joints put together. There's an articulation between the trochlea of the humerus and the trochlear notch of the ulna. It also is associated with another one that's associated with the elbow is the humeral radial joint and the proximal radial ulnar joint. So all 3 of these joints together are going to form, be enclosed in a single articular capsule. So they're showing you all of those different joints. You can see on here that there's some bursa. So elbow bursa, bursitis in the elbow is pretty common. You hear about things like tennis elbow and things like that because we bend that too much. I get bursitis in one of my arms when I do some things around my farm. You have 2 capsular ligaments that restrict the side-to-side movement as well as hyperextension, so you don't bend your elbow backwards too far. You don't open it up and extend and go too far. What keeps that from happening is the ulnar collateral ligament and the radial collateral ligament in the elbow. Elbows don't get dislocated very easily because of the 3 joints and all of this stuff on the outside and then the capsule. But it can happen. So here is showing you the ulnar collateral ligament, and then the right-hand side is showing you the radial collateral ligament. So lots of ligaments holding all of the 3 bones that are associated with the elbow joint together. Moving on to your hip or your coxal joint. This is a multi-axial ball and socket joint between the head of the femur and the acetabulum of the hip bone. The hip carries the weight of the body and thus requires strength and stability during standing and walking. And for this reason, the range of motion is more limited than what we see with the shoulder. The shoulder, you have the true huge range of motion. You have a good range of motion with the hip, but not quite as noticeable. If you see the way they're put together, you'll see why. So looking at this, we're looking at the femur, and you see the head of the femur. It's actually sitting in this socket called the acetabulum. So acetabulum in Latin means vinegar bowl. The word for the chemical term for vinegar is acetic acid. So I guess to early anatomists, it looked like some kind of a bowl. But nonetheless, it's that the head of the femur is almost fully encased in that bone. It's fully into that bone. That's not what we saw with the shoulder. With the shoulder, we saw the head of the humerus touching the glenoid cavity, but the glenoid cavity is like a shallow depression compared to this true cup this is sitting in. And so you don't have quite the range of motion, but you can't have that kind of range of motion with the hip because you've got all of your body weight to move your legs and everything are right there in that hip. The hip ligaments are going to include the iliofemoral ligament, the pubofemoral, and the ischiofemoral. The iliopubal and ischial are the 3 different bones that fuse together to make the hip, and so that is where one end of the ligament is, and then the other one's going to the femur. All of these are going to spiral around the head and the neck of the femur. And they look like this. So if you take a look, you see they've got them labeled there for you. They've got them boxed around them for you. And you can see how you can't even see the head of the femur, and you can't see the acetabulum. And they are together right there because you've got these ligaments that are sitting on top of it. And notice how they spiral around, right? And so that's going to confer a lot of strength, a lot of strength. It's hard to dislocate a hip too. It can happen, but it's a little bit harder to do. So the last of this lecture talks about inflammatory and degenerative conditions. I can't encourage you enough to take really good care of your joints because boy, do they start to wear out when you get older. So bursitis I've touched on briefly. This is inflammation of the bursa that's near a joint. Again, bursa have different names for the different ones that you have. It can cause pain and swelling and tenderness of the bursa and the surrounding area, but it's not inside the joint. This is outside of the joint, right? And so it can result in stiffness because you can't move that particular area. It can be acute, which means it just lasts for a few days. We've all had that. You've overdone something and you've just got like it's that joint is hurting. But it can also be chronic. It can arise from muscle overuse, from trauma, excessive or prolonged pressure on the skin. It can be caused by rheumatoid arthritis, gout, or an infection in the joint. Repeated acute episodes of bursitis can result in a chronic condition, and the treatment for bursitis is going to vary from rest, and ice, and compression and elevation to mild surgery. Usually, they have you take anti-inflammatories like ibuprofen and that sort of thing to help calm that down. Tendinitis is the inflammation of the tendon due to overuse, and it causes pain and tenderness in the area around the joint. And the classic example of this, because I have it in both legs and have had it for years, is Achilles tendinitis. And so that Achilles tendon right there is a heavy duty band, and you put a lot of pressure on it when you're walking and doing all the things that you do. And if it inflames, you literally have to stay off of it for a week or two and not, I mean, like be no weight bearing whatsoever, be in a wheelchair. Well, I think most of you know that I live on a farm, and that is actually not ever going to be possible because I have animals that have to be taken care of every day. So when I can get the occasional time where somebody comes out and helps me with them, and I can take a couple of days off, I notice a huge difference in tendinitis, and that's going to be true for your patients as well. Arthritis is a common disorder of the synovial joint and involves inflammation of the joint. So this is inside of the joint itself. Surprisingly enough, there's more than 100 different forms of arthritis. It can be a part of the natural process of aging. It can be because of damage to the articular cartilage, which is what I was telling about. Be nice to your joints because when you damage them, arthritis will rear up when you get a little older. Autoimmune diseases can cause arthritis, bacterial and viral infections, and there can also be a genetic component to this. So we're going to talk about the 3 most common forms of arthritis, but realize that there are some other forms out there too that you'll see. But the things you're going to see most is osteoarthritis, or OA. This is the most common type of arthritis. It is typically associated with aging and the wear and tear of the articular cartilage, hence the reason why I've had my knees replaced. It just is something that happens to all of us as we get older. Another form of arthritis that you'll see a little more commonly is rheumatoid arthritis, or RA. This is an actual autoimmune disease. This is when your body's immune system has decided that the joint capsule and the synovial membrane that are associated with usually in the smaller joints like your hands and feet, that they're foreign and it starts to tear them up. And as it starts to tear them up, it gets a chunk of scar tissue is replaced in those areas, and it dislocates the joint, so it's not sitting correctly anymore. So the articular cartilage becomes damaged, it's destroyed, it causes the joint to be deformed, causes a loss of movement and severe disability. There is no known cure for RA. There are treatments that are aimed at alleviating the symptoms. Surprisingly enough, with all forms of arthritis, exercise, not heavy duty, go pound the pavement type of exercise, but some movement all the time actually helps. Anti-inflammatories, pain medications, and then there are some anti-rheumatic disease drugs that they can give you out there, and surgery so they can start replacing joints. I have a friend from high school that has rheumatoid arthritis, and I'm not kidding you, she's had at least 20 joint replacements. So, of course, she's had the big joints that she's recently had done, but she started with the small joints. She had to have joints in her hands replaced, and then she had to have some joints in her feet replaced and joints in her ankles replaced, and she's had things fused because this disease has progressed over the years so badly for her. The last type of arthritis that I'm going to talk about is gout. So gout is a common and complex form of arthritis that can affect anyone. It's characterized by a sudden and severe arthritic attacks of pain and swelling and redness and tenderness at one or more joints, most often the big toe. This is where it seems to be the most common when it happens. It can occur suddenly. It usually wakes a person up in the middle of the night. They feel like their big toe is on fire. When they try to step down, it's like they've got glass. And literally what's happening is they have got a buildup of these crystals that have formed in their blood, usually from purines. So purines are found, it's a molecule that's found in things like red meat and shellfish and red wine and things like that. And when you get too much of it, it can settle out into your joints. And when that happens, it's like having sand in the joint, and it just flares up and is extremely painful. There's a drug called alpurinol that people can take to try to make that go down. It will go away. It just takes a few days of staying off of it and using ice and all of that sort of thing. It can be so painful that even just like you can't put socks on, and you can't even have the weight of a bed sheet on it. But it goes back down. So that's what gout is all about. There are other forms of arthritis. There is a form of arthritis that is associated with a post-streptococcal infection, so strep throat. So take care of strep throat if you get that. Lyme disease, I think a lot of people know about Lyme disease, the bite of a tick. There is a form of arthritis associated with that. There's juvenile arthritis. There's just a bunch of different kinds, but the three that I talked about in here are the ones that you'll hear about most commonly. It is not impossible to have more than one form of arthritis. My aunt has slight rheumatoid arthritis in her right hand, and her forefinger in her right hand has osteoarthritis. So you can have both or more than one type of arthritis going on at the same time. All right, so make sure you've studied through all of this. Flashcards, as I said earlier, are your friend in this particular chapter. They're good in a lot of chapters, but this one has a lot of words that look a lot alike. So try those. Make sure you take your quiz, and I will see you for the muscle chapter.